Presenter is presenter. O-D-E-R-A-T-Y. Presenter is presenter. Presenter. Presenter.
Can everyone unmute, mute themselves, please?
Yeah, we are live, please.
Good evening, ladies and gentlemen. Welcome once again to the webinar of Cochin Ophthalmic Club. Today it's the specialty program of the Cochin Retina Interest Group, and it is named as Retinights Season 1. And we have three very interesting cases being presented today. We also have a journal presentation followed by a talk on diabetic macular edema by Dr. Gopal. So before we actually go into the proper CME, a few words about the importance of Helen Keller Day. Helen Keller Day is actually was on yesterday, it is celebrated on June 27th. But since it is overlapping with the All India Conference, we thought we will observe Helen Keller Day today. For CME, as you all know, the Helen Keller was a very inspirational personality who was instrumental in doing so many things for the blind and for persons with disabilities in general. So, as a small tribute to Helen Keller, I'm just making a small presentation about Helen Keller. Most of you would be knowing, many things about her, but I thought that during this day it would be nice if we can remember Helen Keller and what she did for the world of persons with multiple disabilities. Helen Keller was born in 1880 in Alabama in the USA. She got sick at the age of, she was actually born a normal child, but she got sick at the age of 19. She had some fever. A few words about the important. And lost her eyesight and hearing at the age of 19 months. And it was speculated that possibly she had scarlet fever or some form of meningitis. And she went into a shell and got very depressed. But she was so innovative that she tried to make her own home signs to communicate with persons in her own home. Like pull means come, push means go. These small, things she tried to make. But many of her family members and persons around her could not really understand her home signs, and this led her to having severe temper tantrums during her early childhood. Until someone suggested a tutor for her, and then came the legendary Anne Sullivan, who was with her through the major part of her formative years, and she went on to develop so many communication skills and communication materials. And finally, at the age of 19, she got a degree in arts, bachelor's degree in arts. In those days, she was one of the earliest persons, or probably the first person who got this degree, despite being hearing impaired as well as blind. She rose to become an American author, a political activist, and a lecturer. And the story of Helen Keller and her teacher, Anne Sullivan, was made famous by her autobiography, which is called The Story of Life. And it is adapted to the film and stage by the name The Miracle Worker. She was a prolific author. She was well traveled, outspoken in her convictions. And she was a member of the erstwhile Socialist Party of America and the Industrial Workers of the World. And she campaigned a lot for the sufferings of women, labor rights, socialism, anti-militarism, and similar causes. She was inducted into the Alabama Women's Hall of Fame, actually posthumously, in 1971, and was one of the 12 inaugural inductees into the Hall of Fame. This is an old picture of the house in which she lived, and these are some of the pictures of her with her tutor, Anne Sullivan. Helen Keller wrote about 12 published books and several articles. One of her earliest pieces at the age of 11 was The Frost King. At the age of 22, she published her autobiography, which I mentioned before, The Story of My Life, and along with Anne Sullivan and John Macy, who was Sullivan's husband. It recounts the story of her life up to the age of 21 and was written during her time in college. Keller wrote The World I Live in 1908, giving readers an insight as to how one feels, in a world where you can't see, you can't communicate through the hearing medium. She also wrote a spiritual autobiography, My Religion, in 1927, and there was a lot of discussion about that. Keller was a member of the Socialist Party, as I mentioned before. She has traveled widely. She's traveled nearly 35 countries from 1946 to 57. And in my consultation room, I don't know where that picture was taken. In my consultation room, I have a photograph of Helen Keller with Rabindranath Tagore. And she was supposed to have identified Tagore by just feeling his face and his beard. She actually wanted to get married. And fell in love with her secretary, but she was dissuaded by her family. And apparently, in USA of those days, persons with disabilities were actually not encouraged to get married, fearing that the disability may pass on to more and more generations. Finally, she could not get married, and in the year 1968, she passed away in Connecticut, in the USA. So our humble tribute from the Cochin Ophthalmic Club to an activist, a person who encouraged thousands of blind persons, made governments think about the blind, their plight, gave them strength, and made the governments do a lot of things for people with disabilities. One of the pioneers, and we, as ophthalmologists, bow before you on this day, the Helen Keller Day. Thank you so much for your kind attention.
Thank you very much, Dr. Sai Kumar.
Gopal, you can take over.
Yeah. Thank you very much. I would say that this is a Kochi Retina Interest Group program, wherein we have Dr. Giridhar as the chairman, and Dr. Thomas Chirian and Dr. Mahesh Gopalakrishnan, who are very much here. They will be moderating this session. We have arranged 3 case presentations, and there will be brief 8 minutes case presentation, and there will be a 7 minutes discussion after that, so that each case presentation can have about 15 minutes. And then we will have a journal discussion, and then finally a didactic talk on DME. So this is the program. Over to you, Dr. Thomas and Dr. Mahesh, for starting the program. So I think the first case presentation will be by Dr. Pooja. Over to you.
Yeah. Yeah, Dr. Pooja can start, unmute and start. We are back in Cochin Retina Interest Group after so many, probably quite some time. And we used to meet every month physically for our discussion. Actually, Cochin Retina Interest Group started way back in 2003 with 4 members, and then it is nearly 18 years. We will have a good meeting in 2023, international meeting probably. So over to you, Dr. Pooja.
Good evening, sir. Thank you for giving me this opportunity. Today, I'll be presenting to you about a case of a 55-year-old female who presented to us with no known comorbidities, defective vision in the right eye, noticed since 20 years. She noticed a recent worsening of her vision since 1 year. Forward protrusion of right eye was noticed since 10 years. She has consulted at outside hospital in 2004, where she was diagnosed to have regressing retinoblastoma and treated. We don't have the details of the treatment. On examination, her vision in the right eye was 3/60, left eye 6/6 with defective color vision in the right eye. Proptosis examination showed on inspection periorbital fullness more towards the supromedial aspect, increased palpable fissure height with inferior scleral show, no increase in size of the swelling with change in head posture while maneuver or stooping forward, no visible pulsations over the swelling noted, and no prominent vessels over the forehead or eyelid were noted. On palpation, it was a firm mass on the supromedial aspect. Orbital margins are well palpable. No local rise of temperature or tenderness is noted. Swelling was not reducible or compressible. No palpable thrill, and no bruit was noted on auscultation. The patient was having right eye eccentric proptosis. Anterior segment examination, she had early cataractus changes with grade 2 RAPD in the right eye. Fundus evaluation, the disc was normal, dilated and tortuous vessel was noted arising from the supranasal aspect of the disc running towards the lesion. Coming to the lesion, it is a size of about 6 disc diameters in size, punched out with a feeder vessel running towards the superior rim and dipping inside it. And there's some amount of pigmentation noted over the lesion as well as surrounding it. Macula and rest of the periphery was normal. Left eye was normal. Coming to the B scan, we could see a defect in no vitreous echoes were noted, and a punched out lesion with no internal echoes were noted. MRI was advised, which showed a solid, well-defined intraconal mass in the retrobulbar space of the right orbit, as you can see in this image, abutting the retrobulbar segment of the optic nerve and a medial rectus muscle. Suspicious area of disruption was also noted in the sclera. The patient had reports from 2004, which showed a lesion at the site of the present location, amelanotic, as you can see here, about size 6 disc diameters, which was on FFA showing hyperfluorescence by the end of the angiogram. Left eye was normal. We also had a B scan from 2004, which showed a dome-shaped subretinal mass with low internal reflectivity. When we compared with the present B scan, this is the picture. A CT scan at that time was done, which was normal study with a contrast enhancing lesion in the posteromedial aspect of the right globe. At this point of time, we have given the patient options of fine needle aspiration cytology, incisional biopsy, enucleation with excision of the mass. The patient was reviewed after 3 months with complaints of decrease of vision, redness, and watering noticed since 2 days in the right eye. Vision was 1/60 with normal IOP. Limitation was noted in all cases as earlier. Proptosis measurement was the same. Grade 2 RAPD was noted in the right eye. Fundus examination, the disc was hyperemic with disc margins blurring. There is some amount of subretinal fluid draining towards the macula. Dilated and tortuous other supratemporal, infratemporal vessels noted. And the earlier feeder vessel that we have noted has increased in caliber and size. The overall lesion remained the same. However, there is a new lesion of size 2 disc diameters noted towards the nasal margin of the lesion with surrounding pigmentation. As we can see in the earlier picture, we can see some new lesion, pinkish in color, about 2 disc diameters that has newly developed. Left eye was normal. Angiogram showed early filling of the artery, feeder artery. Hypofluorescence was noted on the overall size of the lesion with hyperfluorescence of the new lesion at the end of the phases. OCT showed that the lesion has been pushing from behind, as we can see in the through the OCT scan through the lesion. So on repeat MRI, there was an intraconal orbital mass with extraconal extension towards the nasal quadrant of the orbit with increase in size of about 0.5 mm. Considering the following points of decrease in vision, subretinal fluid being developed and disc margins blurred, we suspected it to be a malignant tumor and asked for a PET scan. The patient was not affordable. Ultrasound abdomen was done, which was normal. Chest X-ray was normal. We went ahead, explained the need for enucleation with tumor excision, and enucleation was done. On examination gross specimen, it's an encapsulated spindle cell neoplasm with whorl and hemopericytoma-like pattern of size 4 into 2.5 into 3 centimeters. Histopathological wise, it is a patternless, as we can see in this picture. This is the capsule. It was a patternless hypercellular spindle cells with thick collagen in between and pigmentation noted. Immunohistochemistry cytology was done on 20X was negative for S100 and it was positive for CD34 marker. STAT6 was positive for spindle cells nuclei, and K67 was showed that there is low mitosis within the tumor. All this concluded that it is a solitary fibrous tumor of the choroid. This is a similar case report that has been documented from solitary fibrous tumor of the choroid. Basically, what are solitary fibrous tumors? These include a hemangiopericytoma, fibrous histiocytoma, and Jane cell angiofibroma. These are rare spindle cell tumors. Most commonly, pleura is involved, hence also called localized mesotheliomas. Their benign orbital masses usually seen in middle-aged adults. Their fibroblastic is differentiated cell type in the submesothelial mesenchyme. This is a similar case report which was done, which is documented, solitary fibrous tumor of the choroid, seen in a 55-year-old male. As we can see here, it's a choroidal lesion adjacent to the optic disc with infrared disc margin edema. There was no RAPD, vision was 20/20. B-scan showed a medium to high reflectivity with MRI image showing left choroidal lesion with no extension along the optic nerve. The patient was managed by giving empirical treatment with IV bevacizumab with PDT. Pars-plana vitrectomy was done with biopsy, which showed spindle cells. However, the progressive deterioration was noted and the patient underwent enucleation. 6 months down the line, there was metastasis even to the liver and brain. 8 years later, the patient passed away. So even though these tumors are benign, they can metastasize in delayed but aggressive fashion. There is one more, this is also a case of solitary fibrous tumor of the sclera that has been documented in a 50-year-old male with vision 20/200, no proptosis, RAPD, subconjunctival mass in the infratemporal bulbar conjunctiva. As we can see in the lesion here, this is a round mass with the sclera extending intraocular and extraocular in the infratemporal quadrant of the globe. Enucleation was done, which was also positive for CD34. Till date, there are 46 cases of solitary fibrous tumors of the orbit being documented. Other sites could be a lacrimal gland and a lacrimal sac. Its close proximity differential diagnosis would be a giant cell angiofibroma and a giant cell fibroblastoma. However, they don't have a fascicular pattern, as well as even though markers are positive, however, giant cells are not present. Thank you. My special thanks to Malini ma'am with the pathology slides.
Very good case, Pooja, with a very long follow-up. You have the old fluorescent angiography and B-scan also. So nearly 18 years of follow-up.
Yes, sir.
Quite rare thing. What I understand is since the mitosis, everything is not much there. It is a low, slow growing, right?
Yes, sir.
Slow growing, yeah, slow growing neoplasm. And for that matter, chemo, everything may not be working also, right?
Yes, sir.
Here, ideally, PET scan has to be done to
Yes,
see.
sir, because
Ideally, no, if the patient was not affording, otherwise PET scan has to be done, right?
to look for metastasis. Yes, sir. PET scan would have
Yeah,
been
that old B scan, if you see, it is showing something like a melanoma with choroidal excavation, and it is typically showing something like a melanoma. In fact, I was thinking it is a amelanotic melanoma that has. What was the treatment given initially in 2004?
we don't have the details, sir. We just have a paper saying that this is one form which is written as query diagnosing retinoblastoma. We tried asking whether
And they may not have treated also.
Yes, sir. So she's not sure. The patient is not sure what treatment has been given.
I had initially
Another
thought that it was a
interesting finding is
retinocytoma or something like that, and they did not treat, but there was no calcification in that. And it said medium to high reflectivity inside, but it was endophytic. But the current ultrasound shows a significant excavation. Pooja, can you just show that ultrasound also once again? The comparison between
the old one
and now.
is old one looks very typical of melanoma, choroidal melanoma.
The availability of the old documents, you are sure that the tumor has a choroidal origin and not an orbital origin.
Yeah. Correct.
Yes.
You see the old, this one, no, left side, it is that there is classical choroidal excavation is there. The only thing, it is not, it is the base is little wider than choroidal. You can get a mushroom like, no?
Yes.
Base will be little small and then it will be like this. So base is little.
But right now, what has happened is it has completely caved in. Probably it's an exophytic growth.
And now it has become extraocular spread, you can say, growth.
Grown into the orbit.
Yeah.
Probably there is a scleral defect which has also come in. A scleral defect through which it has grown outside. So that is the. Anybody else who would like to comment? Pooja, you can off the presentation. Anybody else who would like to comment? Giridhar sir has also joined. Welcome, Giridhar sir. Good evening, sir.
Yes, sir, you're muted.
Divya, Risha.
You can put this as a case report in because it's a very beautiful follow-up for 18, 17 years. No?
The excision biopsy is sufficient, or do you think that she needs any further treatment?
They have removed the capsule also in toto, so it should be fine. And since it is low grade, the chemo will not work. None of the low grade tumors, low mitosis index, chemo will work.
Unless the
And you have to find out whether there is any spread. PET scan probably. Nice case.
Any optic nerve involvement?
Optic nerve involvement was there, no? It was impinging on the optic nerve pressure, not a spread into the optic nerve, but I think it was
color vision was
that is resulting in RFPD. Yeah.
Color vision that suggests an optic nerve pressure effect.
Optic nerve compression probably.
Can we move to the next case for want of time?
Yeah, definitely. Good case. Immediately write it and put in some journal. Now
we're working on it, sir.
Yeah, no working. 1 week you have to finish.
Nikita will present this case from Little Flower Eye Hospital, Angamali. Over to you, Nikita, and Risha and Ramya. Okay.
Good evening, all. My presentation topic is retinal vasculitis unveiled. We have a 23-year-old female who presents with sudden onset of defective vision in both eyes of 2 days duration. She had associated redness and pain. She was clinically diagnosed with dengue fever a week ago. There was no thrombocytopenia, so hence no hospital admission was required, and she was treated symptomatically with paracetamol and antibiotics. Her father and brother also were diagnosed with dengue fever. She had no history of any other significant past medical illness, no history of any contact with TB patients, no history of joint pain, and she's allergic to penicillin. Her visual acuity in right eye is 6/36 and left eye is 5/60 with no improvement in node. IOP is normal in both eyes. Antisegment showed cervical congestion in both eyes with grade 1 cell reaction. The dilated fundus examination of the right eye showed clear media with no vitritis. Disc is normal in size and shape. The CD ratio is 0.4 with nasal blurring of the nasal margins. There is extensive occlusive retinal vasculitis involving both arteries and veins for 360 degrees around the retina, and it's more extensive in the left eye involving the macula. The fundus fluorescent angiography showed occlusive vasculitis with extensive non-perfusion areas, and it involves the fovea in the left eye, and there is disc leak in the late phases suggestive of peripapillary vasculitis. The osity of the right eye showed subretinal fluid with foveal contour maintained, and the left eye showed hyperreflective inner layers. Her lab workup showed strongly positive dengue IgM antibodies, and there was neutrocytopenia and lymphocytosis suggestive of viral infection. After physician hematology and rheumatologic consultations, she was started on systemic steroids in high dose and tapering doses. At 2 weeks, the retinal edema started to resolve. At 4 weeks, the retinal edema is resolving with improvement in vision right eye 6 to 6/18 and left eye counting figures 3 meters. This is the osity of right eye showing resolving of SRF. Left eye showed foveal thinning. At 6 weeks, there is complete resolution of retinal edema with development of NVE and pre-retinal hemorrhages. She was hence started PRP in both eyes. Goniscopy in both eyes showed open angles and no NVA. However, at 8 weeks, she developed subhyalid hemorrhage in both eyes, and the vision has deteriorated further to 2/16 both eyes. She hence underwent pars plana vitrectomy, membrane peeling, endo laser with silicone oil injection. This is post vitrectomy with silicone oil in situ in both eyes. As of now, she is post SOR with her right eye vision maintained at 6/12 and left eye 2/60. Coming to discussion. Ophthalmic manifestations of dengue, although uncommon, has been reported in literature. The manifestations are varied, of which retinal vasculitises constitute 23%. The pathogenesis is a post-immune response triggered by an infection with the virus. It can be primary or secondary. Primary is usually benign. Secondary is severe and occurs after infection with a different serotype. In secondary, the IgG-IgM ratio is more than 1.1, but in our case, it's less than 1.1. Suggests of primary infection, and they are treated with oral corticosteroids. Thank you.
Thank you, Dr. Nikita, for that case. Suppose dengue was negative, what other DD you would have thought? I mean, just because dengue, what other DD you would have thought? Because here it is, I think it is both arterial and venous, both not arthritis alone, no? It is vasculitis involving both artery and vein.
So I would think of Bessett's.
Yeah, that's, I was actually thinking about that only initially.
But the patient doesn't have very high. Yeah, but the patient doesn't have any history of aphthous ulcers or recurrent aphthous ulcers or genital.
You may not. Actually, some of the patients with Behçet's, young fellows present with CRVO or something like that, BRVOs, and if now it has become very stabilized after oil removal, so that means it might have been dengue only.
Yes.
Behçet's, it can even keep on. Hello, Gopal, what do you say?
I want to bring in Dr. Giridhar sir here. I want to ask sir, it's like in dengue, whatever we see usually is a macular involved. Usually the vasculitis is perimacular. Here we have an extensive, pardon me?
Foveolitis.
Yes.
Yeah, usually the vasculitis which is seen is perimacular. Here we have a complete occlusive vasculitis, that too in both eyes. What are your thoughts, sir?
Yeah,
are we missing Behçet's?
I was also thinking whether this is a pre-existing vasculitis which has been detected following dengue, because the bilateral, such an extensive global involvement in such a short period of time, I mean, I do not know whether it can be due to dengue. I don't think we have ever seen such a severe vasculitis in dengue. So whether there is some underlying pathology which is, which is lying undetected, we do not know.
Yeah, Risha wants to speak.
Risha was the person HLA typing can be done. HLA typing can be done, I feel. If it has not been done, I feel HLA typing should be done, because that's the only one test which probably will be very conclusive as far as Behçet's is concerned.
Yes.
Or at least a rheumatology consultation and a complete rheumatology workup can be done, because definitely the picture is not very, very characteristic of a dengue retinal vasculitis.
Sir,
yeah,
sir, since the picture was not very much suggestive of dengue vasculitis and more of like an SLE presenting, predisposing with an viral fever, so we did a complete rheumatology workup. Actually, we did it twice, and we did all the investigations again and again, but everything came to be negative, and that's why we suspected dengue vasculitis only. And in literature, there are 2 or 3 case reports.
I was just wondering whether laser could have been done a little earlier.
A little earlier. Later could have been done little earlier, because we thought maybe with laser, if the retinal vasculitis exacerbation happens, already left eye macula is fovea is involved.
Left eye, the poor vision is because of optic nerve involvement. This is very pale.
Yes.
So there is an element of optic nerve involvement. That's the reason why the left eye vision is very bad. Apart from
And
the
non-perfusion of fovea also.
possibly, I mean, that might not have changed the course, but probably the ischemia could have been taken care of a little earlier. Dr. Divya, you want to say anything?
Yeah, I think when I was there, we had reported one case actually. In fact, one of the case report, I don't know whether Risha came across, extensive peripheral vasculitis, but that patient was diagnosed with dengue, but a patient was having even associated malarial infection also. So that patient had bilateral, this brush fire kind of vasculitis extensively in the peripheral fundus. But in this patient, actually, it is more of arterial occlusion actually.
Yeah,
So,
he has a phlebitis also because there are a lot of hemorrhages close to the veins. So phlebitis with arthritis, both are there in this case.
yeah, but you can get actually even in the periphery also, even in dengue infections. We have seen cases like that.
Actually, I had one patient many years ago, diabetic patient. In fact, he even now comes to me. He is from Bangalore. He's a diabetic, and his retinopathy worsened significantly. That is, actually, he had only mild non-proliferative diabetic retinopathy before dengue, which progressed to high-risk aggressive pedia after dengue. So that is within the course of 2-3 months. So actually, now his vision is only about 2 meters in both the eyes.
No, sir. Did you do a fluorescence at that point of time?
Rapid progression.
Did you do a fluorescence at that point of time? Was there occlusive vasculitis?
No, there was no vasculitis.
Okay.
No vasculitis at all. Only retinopathy. No vasculitis, no hemorrhages, nothing like that. There was a complete, there were a few hard exudates, etc. But I mean, he came with a drop. There was little macular edema in both the eyes, and fluorescein angiography showed bilateral total ischemia.
Other condition, especially in these young females, what we see is Takayasu arthritis. That is one condition where you can get these kind of extensive and with the sudden progression.
That was also rolled out.
Do you get optic nerve involvement in dengue? I am not very sure.
Sir, actually, left eye in that picture, it was looking pale, but it was not that pale. Maybe the photo
left eye defectivation is mainly due to macular ischemia.
Macular ischemia.
Okay.
Right. And obviously, because of the total ischemia to the retina, optic nerve may also become ischemic.
Has been reported in dengue fever.
Okay, Ramya, anything more to add from your side?
Optic neuritis has been reported in literature.
Yeah. Optic neuritis. Yeah.
Okay.
We'll go to the third case.
We'll go to the third case. Very good case.
Thank you, sir.
Again.
Thank you.
Very atypical presentation of dengue. Third case will be presented by Shivam Madan.
Yeah, Shivam, start. Yeah.
Yeah. Good evening, everyone. So my case is a 14 years old male, which came to us with a complaint of sudden onset of blurring of vision in both eyes since 1 week. The blurring of vision started in right eye, but after 3 days, the left eye was also involved. And the vision in right eye was progressively deteriorating. Patient also gave history of frontal headache for 1 week, since 1 week. There was a history of single episode of diarrhea and fatigue 2 weeks ago, and patient has no history of use of any steroid or any other drug history. The vision in the right eye was 6/9 and N12, and the left eye was 6/9 and N8. At this moment, the patient was advised OCT and DFA, but patient came after 2 days. So his vision was deteriorated to 636 in the right eye and N6 in the right eye, and the left eye it was same. So coming to the fundus photo, in this we can see there is a hyperemic disc slightly at the nasal side, with with a well-defined margins, and we can see multiple fluid pockets at the fovea and inferior to fovea. The left eye is similar with the SMD at the fovea with some RP alteration, and inferior to fovea also we can see a fluid pocket here. So at this point, thinking about the causes of bilateral serous retinal detachment in children, we thought of our first diagnosis as VKH disease. Second was CACR. Drug induced also we thought, but since the patient was not having any history, so we didn't thought of this. And coming to systemic disease, we came across some articles in which the leukemia usually presenting as a serous retinal detachments, 3 to 4 articles. So our provisional diagnosis at this point was VKH, CACR, and leukemia we are thinking of. So we planned for OCT and DFA, and investigations were given to the patients. So in OCT, we can see a SRF in the OCT with some hyperreflective dots, and there was increased thickness of the choroid and with disruption of the choroidal vasculature. The left eye OCT also has a similar picture with SRF and the increase in the choroidal thickness. In FFA, we can see in the early phases, we can see some pinpoint hyperfluorescence, which were increasing in the mid and the late phases in intensity and fuzziness, suggestive of some focal leakage in the this focal area only. The left eye was normal. It doesn't show any leak. So comparing the clinical features of our case and what the 3 diagnoses, what we were thinking. So in our case, there was bilateral involvement, and comparing this, the bilateral involvement can be seen in VKH and this leukemia. In CSR, it can also be seen, but not very frequently. Coming to the past history, there was no past history in our patient, and the past history can be seen in VKH. Also, anterior uveitis and neurological, auditory, and dermatological findings can be seen in VKH, but it was not present in our case. Coming to in our case, there was multiple localized pockets, which can be seen in VKH and in leukemia. Coming to FFA, there was in our case, there was a pinpoint focal leaks in a focal area, which can be seen in leukemia, and in VKH, it will be a diffuse leak. And in VKH, we can see a disc leak, which was not seen in our case. And in OCT, in VKH, we can see septa, but this was not seen in our case. And ICG was not done. So coming to blood investigations, the hemoglobin levels were less reduced. The total leukocyte count was raised, and the platelet count was reduced. In the peripheral smear, we found a normocytic normochromic anemia with 69% blast cells. So for this, patient was referred to hemato-oncologist, and bone marrow biopsy was done. The bone marrow biopsy shows increased cellularity, predominantly atypical blast cell was found around 75%, which led to a diagnosis of leukemia. And to further differentiate, the flow cytometry was done, in which 91.1% blast cells were found, and KELA positive, that is CD10, which is a marker of B-cell acute lymphoblastic leukemia. So we came up to the diagnosis of acute lymphoblastic leukemia. So patient was started on chemotherapy, and 3 months follow-up when the patient again came to us, there was a resolution of the SRF. In OCT also, we can see there is a resolution.
Shivam, that was a good one. Did the patient
in this case, Dr. Shivam, now what made you think, what are your take-home messages? Or what are how did you think of leukemia?
I also asked him the same question, sir. By mistake, the peripheral blood smear showed some changes which led us to that direction.
No, why was the peripheral blood smear was done because of a suspicion of inflammation?
Divya, it was your patient. Divya,
yeah. Actually, when I saw this kid, my initial diagnosis, clinical diagnosis was VKH. But then somehow he gave a history of headache, which again might go in favor of a prodromal phase of the VKH. And after seeing the angiogram, but even while asking for the angiogram, I don't know, maybe you get some vibe or something about the patient. I told them, you should get a blood routine and a peripheral smear done. But by the time the patient came for an DFA, the peripheral smear reports were not available. I saw the angiogram. If you can put the angiogram, because two differential diagnoses were, first one was VKH and the second was CSCR. Very rarely you can get these kind of CSCR picture in the young also, but bilateral is little unlikely.
No, bilateral CSCR, Divya, may also occur in corticosteroid secreting tumors elsewhere in the body.
Yeah, so it's like very rare, but you can get. So these are the two differentials I had kept. But
the
somehow,
thing is that, see, CSR, yes, but basically it's a very young patient, right? 20 years old, right?
14 years.
No, 14 years old boy, actually.
So at the age of 14 years, actually CSR is a diagnosis of exclusion.
Yes.
Yeah, if you see a macular detachment in a 14-year-old, the first diagnosis is not CSR.
No,
so that way, I mean, this thing was correct. But what I'm saying is, if you see the angiogram is not showing any disc leak.
Exactly.
Yeah.
And if you see the left eye, the angiogram doesn't show any leak at all.
Yeah. So,
but if you,
therefore, inflammation, I mean, the question of inflammation really becomes very doubtful. I mean, basically, it doesn't look like a VKH type of a picture at all. But personally, if this patient had come to me, I don't think I would have done a peripheral smear. That's why I'm saying, I mean, I don't think I would have done a peripheral smear on this patient. So I might have, empirically, I might have started steroids. Okay, just to see what's happening. Basically, because although the clinical features are not very diagnostic, but it's a young patient, serous macular detachment, you understand, basically, and possible bilateral disease. So all these things put together, suspicion of an early inflammation or something like that, I would have put on empirical steroids. Steroids, it might have responded to steroids also. So it might have gone on like that. So basically, there's a lot of take-home messages in this. So in a young patient who comes like this, such a picture in a young patient also is very rare. So, I mean, this is a case, again, which can be reported that, this leukemia presenting as bilateral serous macular detachment or whatever it is. I mean, it's a very rare presentation. I mean,
yes. Sir, our guest, Dr. Sai Kumar, wants to say something to us.
You have made me guess. Thank you. Thank you. No, I think this question was asked to Divya multiple times during our class also when this was presented. She kept on saying, I had some hunch there's something wrong. Doesn't fit into anything. So I just, gave a blood. Just
no, actually,
those things are actually leukemic infiltrates. I mean, what are those lesions actually histologically?
No, actually, there are two ways that these leukemia can present in the ocular. One is the direct leukemic infiltrate. Second is the secondary hematological changes which causes those. So actually, in this case, definite leukemic infiltrates kind of a thing is not seen there. Seeing the increased choroidal thickness, maybe the secondary hematological or
the retina
changes.
also does not show any other changes. No, there are no hemorrhages.
Yeah, so it is a secondary what you say, that hydrostatic or the hematological changes that which might have caused this increase in the choroidal thickness and cause these kind of manifestations. So two ways: one is direct leukemic infiltration. Second is the secondary changes which can happen. So this might be likely more like a secondary change, but that typical inflammatory features are not there in the DFA. That is the point where, like, I had a strong suspicion that we should rule out other causes before labeling this as just an inflammatory or a VKH. So that angiogram was the one which was, clue in this case. But if you look at the case reports, there were cases wherein a typical leakage of the VKH features are also seen, and still the patient had an underlying leukemic manifestation. So it's little tricky in those situations.
One more thing that probably we can look for in such cases where there is a small confusion would be the choroidal thickness. So if the choroidal thickness is high, then probably it will go more in
here
favor
it is
of
very
VKH.
high. Here it is actually, here it is very high. And in fact, the choroidal architecture is also disorganized, just like a VKH. I have one more. I had recently one 14-year-old boy with bilateral leakage. There were two differences from this case. One, there was mild anterior uveitis also, and there was disc leakage. So I started. The Mandu was positive, not badly positive, but Mandu was positive. So ultimately, I was little worried to start steroids. So ATT was started. Then I started steroids. It was not at all responding. Both eyes going into exudative RD. Then I gave IV methylprednisolone for 5 days. Then also it was not at all improving. Then I think new immunosuppressives was started by rheumatologist. It has started responding, but within 1.5 months, it has started like a sunset glow fundus. It was a sunset glow fundus. So my diagnosis was leakage only, but dramatic worsening over the 1.5 months, just because of the TB positivity. So in that case also, after seeing this, I told them to do a peripheral blood smear and come. Because it was not responding to our steroid.
Actually,
So
in
we
some
learned from
cases,
each case something.
Is the child under follow-up? Is he in remission?
yeah. No, he is actually doing good actually.
Thomas,
And
anything? Thomas, do you wanted to say something?
Yeah, I was just asking whether the patient had any fever or anything as a pointer towards leukemia.
no, only 2 weeks back he had a headache and bout of vomiting. So they attribute it to some kind of food poisoning or something like that.
And was the child sick?
No, not at all. That was
No,
the
no.
main problem.
Not good.
lymphadenopathy.
Actually, that time when we saw the kid actually in the OPD, he was otherwise very healthy. So that is the reason why we did not think initially of any of these things. So,
I
but
think,
see.
Okay, so Dr. Giridhar sir asked, what is the take home from this particular case? So I think the take home is that we should do a proper clinical systemic examination. And probably if you are treating the patient before that, a basic blood workup, etc., can be a great addition sometimes.
And in atypical presentation, always be ready for surprises. You should have some lateral thinking, because we do all these things only by hearing these sort of cases from elsewhere. No? So whoever watches this program, they may be having
at
a
least
new
See patient
take-home
as a
message.
whole, not I only.
Yeah. So with that, can we move to the next?
Remia wants to say something.
Yeah,
Remia wanted to say something.
Remia, please.
No, in AML and CML cases in the last stage of the disease, the most common presentation is bilateral cystoid macular edema, not this kind of edema when you have retinal fluid. So most commonly, whenever you see bilateral cystoid macular edema, especially in children or in elderly people also, think of leukemia as one of the differential. Intractable cystoid macular edema. Not relating to diabetes. Not related to other systemic features.
I had a diabetic patient whom we were giving continuously anti-VEGF injection, absolutely no response, and it turned out to be myeloma. So hematological malignancy has to be thought about if your response is bizarre or not according to the textbook.
And myeloma as well as leukemia in diabetic retinopathy, rapidly they will go into proliferative diabetic retinopathy, and sometimes the viscosity may also play a part in it. Okay. Can we move to the next?
Thank you, sir.
Yeah. Dr. Dinesh.
Yes, sir. Good evening, everyone, and thanks for the opportunity. So the topic of the journal club is what explains anastomosis in the pachychoroid spectrum diseases. So it was published in Ophthalmology Retina, September 2020 by Matsumoto et al. So pachychoroid, the recent concept was defined as a choroidal thickening associated with the dilatation of the outer choroidal vessels. Pachychoroid spectrum diseases included CSR, PP, PNV, pachychoroid neovasculopathy, and polypotic choroidal vasculopathy. And the detailed understanding of the pathophysiological features of the pachychoroid is needed for optimal treatment. In one of the study by Pang et al. Using ultrawide field ICG, dilated choroidal vessels were observed from the posterior pole to the ampulla of the vortex vein in CSR patients. And in the other study by Dancing et al., by using the in-fast OCT, they have demonstrated dilated outer choroidal vessels, so-called pachyvessels in the pachychoroid spectrum diseases. Moreover, one of the study by the Matsumoto et al., CCT, that is the central choroidal thickness and the ratio of the luminal area and halide layer to total choroidal were significantly higher in acute CSR compared to the chronic CSR. So in pachychoroid neovasculopathy, anastomosis between the superior and the inferior macular vortex vein were observed more commonly than in healthy eyes, which was published by Matsumoto et al. Only in 2019. And they have noticed that the choroidal neovascularization was present above the pachyvessels in all these PNV cases. So all these reports indicate that the long-standing congestion characteristics of the vortex vein may be a pivotal causative factor in a pachychoroid spectrum diseases. And Yanuji et al. Have described that the CSR can progress to PNV or PCV with the development of the type 1 CNVM. So in this study, they have evaluated the vascular changes affecting vortex vein in eyes with pachychoroid spectrum diseases. Coming to the methodology, it was a retrospective study done in 2018 to December 2019 at Japan, and they have included 216 eyes of the 209 patients of the pachychoroid spectrum diseases, and there were 25 eyes in each of the group as control. So the purpose is to evaluate the vascular changes in the vortex veins at the posterior pole in the pachychoroid spectrum diseases. All the patients underwent a complete ophthalmologic examination, including slit lamp biomicroscopy, color fundus photograph, DFA, ICG, B mode images, OCT images, in-fast images, and the Octa with the help of the Plexlight 9000. They have defined pachychoroid as pathologically dilated outer choroidal vessels on B mode or in-fast OCT and regional choroidal vascular hyperpermeability on ICG images. CCT, central choroidal thickness, was not included among the pachychoroid criteria because CCT is influenced both by the age and the refractive errors, and pachyduction can also be seen in the pachychoroid spectrum diseases. They have defined CSR as pachychoroid accompanied by the serous macular detachment. Fundus angiography shows the dye leakage, and CNV was ruled out with the help of the angiography and Octa. PCN was diagnosed if CNV was associated with the pachychoroid detected by the angiography or Octa or a combination. And polypoidal choroidal vasculopathy was diagnosed by the presence of the polypoidal lesions along with the PCN features. So the main outcome of the study was vortex vein anastomosis at the watershed determined using with the help of the in-fast OCT, and they have differentiated between the cases pachychoroid spectrum disease patients and the healthy controls. So coming to the results, the table 1 shows the pachychoroid spectrum diseases in which there are 92 patients in the CSR, 61 in the PNV cases, and 63 in the PCV. So here we can see that the age is maximum in the PCV cases compared to PNV and CSR. Central choroidal thickness was maximum in the CSR compared to PNV and PCV cases, and vortex vein anastomosis was seen in 90% in CSR, 95% in PNV, and 100% in the PCV cases. Coming to the table 2 of the healthy control eyes, there were 25 patients in each of the group, and the most important point is that the vortex vein anastomosis was also seen in 40% in CSR, 48% in PNV, and 36% of the PCV cases. So this was the figure 1 showing the image of the healthy eye. So in the fundus picture, this is the in-fast OCT in which they have shown the superior and the inferior macular vortex veins, and this is a watershed area, horizontal watershed area, and this is normal BCN OCT. Figure 2 shows the image of the CSR patient. Here we can see that in the OCT, we can see the serous macular detachment. In-fast OCT in the figure B, here we can see that there is a loss of the watershed area, and there was anastomosis of the superior and inferior vortex veins. Octa shows no network. DFA early and late phase shows few window defects with leakage of the dye. And ICG shows dilatation of the choroidal vessels along with some choroidal hyperpermeability. This is a figure they have shown for the pachychoroid neovasculopathy in which OCT shows SRF along with the double layer sign. In-fast image also shows the loss of the watershed area and the anastomosis between the vortex veins. Octa shows a complete clear active network along with the surrounding halo. DFA shows some window defects along with some leaking, and ICG shows suspected CNVM at the macular area. The last figure shows the figure of the polypoidal choroidal vasculopathy. OCT shows SRF, PED with serum area. In-fast OCT shows the macular vortex vein anastomosis. Octa shows the network And a DFS shows the window defect along with the leakage of the dye. And most important, the ICG shows the network, branch vascular network along with some polypoidal choroidal lesions. So coming to the result, the important points were that the central choroidal thickness in each pachychoroidal spectrum diseases was significantly greater than the corresponding healthy control eyes. Rate of the anastomosis was significantly higher in pachychoroid spectrum diseases than in the healthy control eyes, and it was statistically significant. Rate of the anastomosis was significantly higher in PCV compared to CSC eyes, and about 80% of the eyes were male gender. Coming to the discussion, vortex vein anastomosis observed in 90% of the eyes with pachychoroid spectrum diseases compared to the normal control eyes. And study demonstrated by the Matsumoto et al. Demonstrated macular vortex vein anastomosis in the PNV cases. Several studies revealed the collateral formation resulting from the choroidal venous anastomosis owing to vortex vein congestion. So they've speculated that the macular vortex vein anastomosis may be a common morphological feature of the pachychoroid spectrum diseases, and the anastomosis are observed more frequently in the PCV compared to the CSC. Because in the PCV, we have noted that the age where the oldest age and the CSC are compared to the younger age. So there was the long-standing congestion of the vortex vein in the PCV cases compared to CSR cases. So we have noted that the rate of the anastomosis was higher, that is 100% in the PCV compared to the CSR cases. Collateral formation, we know that there is characteristic of the retinal disease, for example, would be RVO cases. Vortex vein have a segmental drainage field divided by the horizontal and the vertical water shades. But in this study, we have also noted that the anastomosis was also seen in 40% of the healthy control eyes. So in eyes with vortex vein congestion, the potential anastomosis would be used as a new drainage route. Pachychoroid spectrum diseases associated with greater central choroidal thickness than in healthy control eyes in this study have been noted. So the dilated vortex veins under the fovea seem to contribute to the choroidal thickening in the pachychoroid spectrum diseases. And interestingly, we have seen that the central choroidal thickness was greatest in the CSR patients compared to the PNV and PC. The choriocapillaries and the satellite layer of the choroid becomes thinner in the pachychoroid spectrum diseases because of the dilated vortex vein, which results in ischemia of the inner choroid, especially in the macular area because of the high metabolic activity. And by the study by the Matsumoto et al., they have also shown that the choroidal neovascular membrane in all these cases was always above the pachyvasus, which is an important finding. CNVM accompanied by the pachychoroid may develop polypoidal lesions because of the long-standing vortex vein congestion as we seen in the PCV cases. But every study has some limitations like retrospective nature, small number of the healthy control groups, and the current participants were all Japanese, so it may not be applicable to the larger population, including all racial groups. But take home message that the conclusion of the study is that long-standing vortex vein congestion may lead to the development of the pachychoroid spectrum diseases. Choroidal congestion may be compensated by new drainage routes formed by the vortex vein anastomosis, and anastomosis between the superior and inferior vortex vein was found to be a common feature in the pachychoroid spectrum diseases. Thank you for your listening.
Basically, I mean, I think this was presented in the class, I think so, isn't it?
Yes, sir. Yes, sir.
I mean, I think we can put the thing open for discussion. The thing is that basically the finding is very interesting. Actually, vortex vein abnormalities have been described in wide-angle, ICG angiogram in patients with pachychoroid disease. The term pachychoroid itself now is in a process of evolution. And basically, we really do not know what exactly is pachychoroid. So basically, that itself is definitely, even there is a very recent editorial in Retina, and a very interesting editorial actually, where they have questioned some of the very definitions of pachychoroid. That is, anyway, leaving aside that, differential drainage into the vortex, I think, has been documented very, very well in the wide field ICG angiogram, where there is a differential draining to one particular vortex. Now, whether this anastomosis is there right from a very young age, is something congenital, or whether it is acquired during the course of the, as the person is getting older, whether it's something that is acquired, we do not know. Number three is, I think, only in NFAS images they have shown that, isn't it? It's only in the NFAS images. Is it in the,
Yes, sir. Yes, sir.
Yeah, they are in the NFAS images.
NFAS images. So basically, you see, the problem is that unless and until you have that sort of a very good imaging facility, you are not in a position to make a diagnosis. So we really do not know. So the number of patients with CSCR or any form of pachychoroid disease undergoing this sort of a ICG angiogram itself is so small in number. So being pure, I mean, therefore we really do not know. So ideally, I think that patients with, in fact, patients with central serous chorioretinopathy, I think have to undergo ICG angiogram. They should undergo NFAS ICG, NFAS imaging of the choroid for us to study the choroidal pattern. Dilatation of choroidal vessels towards the fovea is one of the most important characteristic features in pachychoroid disease. I mean, in the definition of pachychoroid disease, where you, unlike in a normal person, where the vessels taper towards the center of the macula, here the vessels actually dilate towards the center of the macula. So that we have also seen with serous chorioretinopathy, especially chronic CSCR, doing the ICG, we see that, you know, right in the center, we see these dilated choroidal vessels. So there are a lot of unanswered questions as far as these entities is concerned.
So before we go to the next session, Dr. Dinesh, can you just, for the interest of the audience who may be listening, can you just talk about the pachychoroid spectrum and the diseases which come under that? And Dr. Dinesh, can you just talk about that? Yeah.
So pachychoroid basically was defined, earlier it was defined as a central choroidal thickness more than 300, but now the definition has been changed. Basically, it's a dilatation of the choroidal halo vessels, so it is not important. The CCT, the central choroidal thickness, was not so important. It was basically the dilatation of the choroidal halo layer vessels. And then in the pachychoroid spectrum diseases, the disease which come is CSCR, pachychoroid pigment epitheliopathy, pachychoroid neovasculopathy, and polypoidal choroidal vasculopathy. And now the recent articles and many of the studies have been taken, and they are also thinking that maybe choroidal hemangioma may also can be included in the pachychoroid spectrum diseases. Thank you, sir.
Okay. Thomas, anything to add? Ramya, Divya, Mahesh?
Nothing much. Go ahead.
Sir, Dr. Giridhar, sir, anything to add on pachychoroid spectrum, and what are your thoughts on that? You're muted, sir.
No, I think I mean, I have already said a few points.
Okay.
Yeah, I mean, I don't know. I mean,
then I think we'll move to the last segment of.
I think basically, I mean, I think we have to distinguish between a simple CSCR and a complex CSCR. Actually, recently, Dr. Jai Chablani has come out with some proposition of a new classification of central serous chorioretinopathy. I do not know whether any of you have come across this particular article. This came as an editorial in Ophthalmology Retina recently, just about a couple of months ago. I had a lot of what do you call, not skepticism, but I felt that there are a lot of unanswered questions in that classification also. So he has tried to divide CSCR into simple and complex. And simple is basically when you see an area of autofluorescence which is less than 2 disc diameters. Complex is when it's there more than 2 disc, and certain other features also. So it is still, I think they are trying to validate that. That may take some time, and they're trying to. But then I had a Zoom meeting with Chablani about 1.5 months back. After reading this article, I thought I would just talk to him. So he said we have a Zoom chat. So I put up all my doubts. So basically, you have to distinguish between simple and complex CSCR. I think there are 2 types as far as CSCR is concerned. The simple one is the ones which, you know, probably do not have many of these features which Dr. Dinesh has quoted. And the complex ones are the cases where basically what Dinesh has reported. Now, if you see the peripapillary pachychoroid syndrome, I mean, where you see this peripapillary involvement, which is usually bilateral, and if you do ICG angiogram in those sort of cases, you see some of these features which Dr. Dinesh has was explaining today, because you see these dilated vessels. You also see differential drainage into the vortex. So all these very characteristic choroidal features are very evident in peripapillary pachychoroid syndrome, which is a variant of central serous choroiditis. So personally, I feel CSCR is basically two types. One is a simple type, the other is a complex type, where you keep on getting it, it becomes chronic, and the patients develop. And if you see some of the complex cases of CSCR is always bilateral. It's very rarely unilateral. Yeah. Most of them have bilateral disease. So basically, so there is a lot of unanswered questions as far as central serous chorioretinopathy is concerned. I mean, so.
Ramya, you wanted to say something? No. No. Okay. Okay. Then we will go to the final segment of this presentation. So we will have a small talk on Ozurdex in the management of diabetic macular edema. I hope you are able to see my slides and hear me. So to start on, we will have first some guidelines and consensus recommendations from different countries and EURETINA, and then we will go to some of the clinical studies which have been there. So EURETINA guidelines for the management of DME. Ozurdex fits in, as a preferred corticosteroids. Ozurdex is the preferred corticosteroids and can be used first line in pseudophakic eyes, first line in patients with previous cardiovascular or cerebrovascular events, and can also be used first line in patients unwilling to attend monthly injections and monitoring in the first 6 months. This is the EURETINA thing. So as we know, the non-central, basically we will do laser, and it is about the central involving DME that we are going to talk about this. So if there's a history of major cerebrovascular event or cardiovascular event, then corticosteroids is the better thing. If there's a tractional macular edema, it may be a good idea to just start the patient on corticosteroid and anti-VEGF to see if the edema responds. And if it does not respond, obviously we will go in for vitrectomy. In pseudophakic eyes, it's corticosteroids more often than anti-VEGF to reduce the number of treatments, etc. And in phakic eyes, it would be anti-VEGF more than corticosteroids. And in patients not willing to come for monthly injections, yes, Ozurdex is a possibility. So in a corticosteroid, basically you will require IOP to be monitored very carefully, because IOP elevation is there, but IOP elevation in dexamethasone is much lesser than that in triamcinolone, and cataract is also much lesser than in triamcinolone. My own personal experience would say that in patients who are on Ozurdex, by the end of second year, they will require a cataract surgery, whereas in triamcinolone, by the end of first year itself, by about 9 months, 8 to 9 months, they will develop cataract. So let's go to some countries where they have looked at the role of Ozurdex. In France, what they have done is a first-line treatment. What are the factors? One is lens status. If it is pseudophakic patient, then obviously Ozurdex, whereas phakic patient, it is anti-VEGF. Retinal status. Whenever we have inflammatory mediators like submacular detachment, high reflective spots, or many hard exudates or chronic DME, Ozurdex is preferred. Whereas, and also history of vitrectomy. But if there is rubeosis iridis, then anti-VEGF is what is to be used. Other comorbidities like MI or stroke, Ozurdex. And if there is glaucoma, definitely don't use Ozurdex, go for anti-VEGF. Then poor compliance, yes, Ozurdex. And a second line, if visual acuity gain is poor, anatomical reduction of OCT is less, then failure of treatment, recurrence is too common, then we switch on to the other treatment. Now let's come to another country, Italy. So again, Ozurdex can actually reduce the treatment burden. And these are the, first line in pseudophakic eyes post-vitrectomy, any history of stroke and MI, and difficulty attending frequent appointments, etc. So anti-VEGFs as first loading dose and eyes with persistent edema, then you move to Ozurdex. And if anti-VEGF is not responded, then also you will move to the other Let's look at Spain, which is the next country. There is a, the DEX implant, there's a DEX Delphi approach in treatment naive eyes, pseudophakic, if patient is undergoing cataract surgery, a history of stroke or CMY, and poor treatment adherence and vitrectomized eyes. These are the conditions in which even treatment naive eyes you will go for Ozurdex. And it has a longer effect, and so it's much better that way. For switching, after 3 anti-VEGF injections, if there is not responding, then you will move towards Ozurdex. And inflammatory scenarios like high inflammatory component, the biomarkers in OCT, phacoemulsification is needed, and only ocular hypertension with pressures are controlled. These are the conditions in which you will use Ozurdex. So now treatment naive patients, actually we in our own practice, we seldom use Ozurdex as a first line agent in many patients, basically because anti-VEGFs are found to be, and multiple injections are there. But we look at some studies, and this is a study which actually looked at anti-VEGF versus Ozurdex. Okay, there's a PubMed search of about 189 studies, out of which less than 6 months follow-up and less than 10 patients studies were excluded. So that got us about 63 studies with 32 anti-VEGF and 31 Ozurdex. Okay, anti-VEGF studies were about 6,842 eyes, and baseline visual acuity was 57 letters, and mean follow-up was 6 to 48 months. Ozurdex, there was about 1,700 eyes in about 31 studies, with mean baseline visual acuity was a little lesser than anti-VEGF studies, and mean follow-up was about 10.3 months, range 6 to 36. Now, anti-VEGFs, 6,800 eyes, there was a mean injections of about 5.8 injections, and mean visual acuity is about 62 letters, and the mean gain was about 4.7 letters. In the same time, with 1.6 injections mean, you had about 9.6 letters of improvement with Ozurdex. So with less number of injections, we had more visual acuity gain. So the author's conclusions were that Ozurdex is better visual acuity improvements in real life than in interventional studies. But in anti-VEGF treatments, the interventional studies that we always hear, the RISE, the RIDE, all those next trials which are coming out, they have significantly better results. But when we look at real world evidence, that number of injections are not usually possible. This is the anti-VEGF versus the Ozurdex studies regarding treatment naive and previously treatment. There's about 5-letter improvement here versus 12-letter improvement in the Ozurdex side. And even in the previously treated, about 4.8 letters in the anti-VEGF and about 8.6 in the Ozurdex studies. Okay, so naive status confer better functional response, and actually patients with low baseline visual acuity can also improve significantly. So this is the baseline visual acuity. With less than 50 letters also, there is about 10.5 letter gain in Ozurdex. Here 10.5 as compared to 4.3 in the anti-VEGF. So this is real life, not interventional studies, not clinical trials. So real life studies suggest that with maybe less than 2 injections mean in a year, probably Ozurdex gives a better results than anti-VEGF. Now we'll look at this IRGRAL DEX study in which they looked at 24 months DME patients, treatment naive or refractory eyes in the real world. So this is actually the blue is the treatment naive patients in which there was an improvement of about 11.3 letters. And in the refractory also, there was an improvement of about 7.3 letters. That is a very good result in about 24 months. And central macular thickness also fell down by about 252 in the refractory eyes and about 304 microns in the treatment naive eyes. So this is the next study which looked at Ozurdex in different subtypes of DME. We looked at treatment naive and refractory in diffuse spongy edema, cystoid edema, and serous retinal detachments. And refractory means after 3 consecutive anti-VEGF injections, there was worsening or no partial response. And mean number of injections at baseline was about 7. So then Ozurdex was given and 6 months follow-up was done. And this is the result. You can see that in the naive, treatment naive, the visual acuity improved significantly to about this much. And in the non-naive, which is the refractory also, the visual acuity improved. So the mean change is about 4.4 letters, 3.8 and 3.1. So, but in the naive, treatment naive patients, the improvement was much more than that. So that means that treatment naive has a much better visual acuity gain than the refractory ones. And again, this particular slide shows that the anatomical response was much better in submacular detachment type of patients. Now, there was one study, Ozurdex versus aflibercept in patients with DME. Compare the efficacy and safety of Ozurdex and aflibercept. So this is the dark blue is the dex and the light blue is the aflibercept. This is the central retinal thickness reduction to less than 300 in Ozurdex. Okay, anatomical outcomes are better, and this is the visual acuity outcomes. You can see that the dex had about 56.8, and aflibercept had about 52.7. So that is a visual acuity gain. So the increase in mean visual acuity in a 12-month follow-up favored the aflibercept. When the only pseudophakic eyes were evaluated, the main improvement of visual acuity was similar between the groups. That is understandable because Ozurdex induces some increase of nuclear sclerosis, etc. So in summary, the EURetina and experts from different countries, France, Italy, Spain, recommend updates to clinical guidelines and treatment protocols for DME. Current evidence shows that Ozurdex is useful in pseudophakic, vitrectomized, phakic eyes that are not young, clear, and crystalline, and poor treatment adherence, DME with suspicion of high inflammatory component, especially with OCT biomarkers, SMD, hyperreflective foci, many hard exudates, and whenever there is a history of cardiovascular events. That is a thing that Ozurdex can be helpful. Thank you very much.
Gopal, shall I one or two points for discussion?
Sure. Please.
If at all you have to repeat an Ozurdex injection, how early do you repeat it? And how frequently can you give Ozurdex?
Yeah, excellent question. So I would see when you are using Ozurdex, we are only doing PRN treatment. There is no loading, there is no fixed dosing, nothing. It is only PRN. So which means that we will follow the, in the first time when you give Ozurdex, probably after a month, we should basically call them to look at intraocular pressure, etc. But then after a couple of Ozurdex, you know how much time that this person will have after one injection. So maybe our frequency of follow-up will also reduce. And I call these patients maybe once in 2 months after that initial thing. And then whenever the edema comes back, or if the vision starts dropping, that is a point of time where I will consider the next Ozurdex, and mostly after 4 months.
I must confess that I used to give a lot more Ozurdex a couple of years back, but then Ozurdex went out of availability for some time, and we lost that habit of giving Ozurdex. Now, during this pandemic time, I think we should be using more of Ozurdex because our patients don't come for review as they used to come earlier on. Sometimes they turn up after 6 months with very bad macular edema. So this is probably the time when we should get back to Ozurdex, at least in pseudophakic eyes, as a primary treatment.
Yeah, what is your opinion?
That is actually it works. All of us know it works beautifully because we have started with Triamcinolone sometime back, 16 years back. So it works. But I usually I am trying to give more Ozurdex based on the biomarkers. A lot of lipids, serous detachment, NPDR. Unfortunately, a lot of cases we get DME with PDR changes. Those are out of question for Ozurdex. So, I mean, Thomas said a valid point. We can call them. Yeah.
Sir?
Yes, yes,
And
please.
in
Yeah.
post-COVID, is there any change in choice of injection? Because there is more chance of thrombus formation in post-COVID post-COVID times, and anti-VEGFs. Is there any contraindication?
Is there a more chance of thrombus formation as a long-term sequelae of COVID? I don't think, because when there is a D dimer is high,
but immediately they are giving antiplatelets for
immediately,
3 months. They are
yeah,
giving, no?
not in every case where there is inflammatory
D-dimer
markers.
variation.
Yeah, D dimer, all these things are positive. Then only they give. If such a thing is patient is on such a thing, we may probably avoid. But post-COVID cases, now every patient coming to the OPD is either vaccinated or post-COVID. If you ask, these two things are there with every patient. So after COVID, the anti-VEGF treatment strategy has not changed. But the recent COVID, yes, probably we have to think about all these inflammatory markers and then give anti-VEGF, because theoretically it is thrombosis.
There could be quite a few asymptomatic or subclinical COVIDs going unnoticed, and they could also land up with
That is another thing.
Yes,
Yeah,
Dr.
yeah,
Sai,
that is another
please.
thing.
Two
Yes,
questions from a non-retinologist. Is triamcinolone finally out? Intravitreal triamcinolone?
No.
Is it totally out?
No, no, no.
So what are the
I
indications?
also think no. Dr. Sai,
My
triamcinolone is
indication
effective. Triamcinolone is effective, and triamcinolone can be the first choice, but the problem is the pressure effect of triamcinolone is very high.
That is my second question. Ozurdex definitely is more glaucoma friendly.
Yes.
Compared to triamcinolone.
Yes.
Triamcinolone we use every day in operation theater for staining the vitreous. Okay, so it is not out.
No, but that's washed out. I'm asking about intravitreal triamcinolone.
Intravitreal.
See, the thing is, cataract will develop by the end of the first year, and glaucoma will be seen in about 50% of the patients after 2 or 3 injections. That is the problem.
Probably I have not given intravitreal triamcinolone for the past 4 or 5 years, definitely. Because many of these cases where you they cannot afford Ozurdex, we may give to Avastin, and which is also not very expensive. So there is a cushioning drug.
In pseudophakic, the non-affordable ones, Avastin maybe lasts for 2 to 3 weeks and the macular edema bounces back, but triamcinolone stays for a couple of months. So I give
posterior subtenon. I give posterior subtenon in those cases.
As far as triamcinolone is concerned, I mean, for the younger people, ophthalmologists, I think there are some important things which we should remember. One is that this is one drug, if you are injecting into the vitreous, your patient has to come back to you. This is very important. If you are having a non-compliant patient, I will never even think of injecting triamcinolone. I remember Mahesh knows one of my patients nearly 20 years ago. Actually, I injected just 2 milligrams of triamcinolone in the pre-anti-VEGF era for a diabetic macular edema, and he had to return to the Gulf. I gave him a letter saying you have to meet an ophthalmologist and check your intraocular pressure regularly. That man was going to the ophthalmologist regularly, but unfortunately, that fellow never told him his intraocular pressure is high, because Indians are treated like that. Unfortunately, we Indians will never learn that. So finally, he came back with a no PL, glaucomatous optic atrophy, couple of months after injecting triamcinolone. So once we inject triamcinolone, we have to make sure for the next 2 months the patient will come at us regularly, because incidence of glaucoma is quite high. Number 2, I think maximum 2 milligrams, not more than that. I used to give triamcinolone with PDT, because when we do PDT for PCV, we get post-inflammation, post-PDT macular edema. So next day, little triamcinolone, you can give Dexa also, 1 milligram of triamcinolone and the anti-VEGF 1 week later. So that you know that immediate inflammation is taken care of, because Mahesh will know that some of our patients initially with PDT, they used to come with a rebound macular edema in the first week after PDT, especially those sort of PCV cases where the anti-VEGF was having a very poor response. So in those cases, next day you just inject anti-VEGF, it's already a non-responder. So finally it happens that, you know, so they come back like that. So these are one or two small, so I have also stopped triamcinolone. I have not injected for many years now. And so for this, because of once you burn your fingers and there is an alternative, basically, you know, so in poor patients, we want to give it, but poor patients are the ones who may not come back to us. That is the problem. So follow-up and compliance among these lower socioeconomic is worse. So they may not come back, and finally you may land in a problem.
Yeah, there was a question in the chat box which asked if the patient is non-responsive to anti-VEGF in terms of DME, but he's responsive to Ozurdex, but the pressure rises. So what would be our approach? So I had a few patients like that, which is completely not at all responding to the anti-VEGF agents, but responding well to Ozurdex. So I had done a trabeculectomy in those patients and continue with Ozurdex injections, maybe 2 injections or 3 injections in a year, and macula is flat.
Many a time you don't need that. You can manage it with glaucoma medication also.
So,
but the problem is initially, if the IOP rise is only 25-30, the second time it may go even very high. So I don't think that the risk of glaucoma in the second time will be more violent.
So let us ask the question to our glaucoma surgeon in the panel.
Yeah,
Dr.
actually, it's not a bad idea to just have a look at the disc before you decide on this, and look for a history of glaucoma, whether any history of steroid response he has had in the past following some surgery or something. I think these points should definitely be noted, and in such cases, if possible, avoid the Ozurdex and triamcinolone and go in for an anti-VEGF. But if you look at the list of anti-VEGFs that is done for diabetes, I think anti-VEGF still is much more than Ozurdex in our hospital. Is that true in every place?
Yeah.
Yes.
Yeah.
No, basically, I think in India, at least, not in India, in our practice, I think we are not using much of aflibercept in diabetic macular edema. So basically, I feel that in patients who are poor responders to anti-VEGF, when you say, I think it is mainly ranibizumab and bevacizumab.
Correct.
So the thing is that in situations where Ozurdex probably is creating some issue, probably it will be worthwhile to try aflibercept because it's quite effective in DME. So it's very effective rather in DME, and even the injection rates may be a little less. And since the scheme of Eylea is there even for DME, so patients can be enrolled in that. So that is an alternative you have in situations like what Gopal Pillai was saying now, where there is a significant, I think as Mahesh said, if the intraocular pressure rises to 21, 22, 25 and all, probably it's a very mild increase which is controlled with this thing. And if it's coming back to 14, 15 after the Ozurdex disappears, probably the risk of injecting a second dose is very less. But in the first dose itself, it has gone to quite a high level of 30, 34, or 28, 30 and all that stuff. And it's taking a long time for it to come back to normal in the absence of any ATMs. Then probably giving a second injection in that patient, maybe you're taking a little bit of risk, which is avoidable because we are having other options. If there are no other options, then obviously you have to take that risk. But if there is another option available, whether it is necessary to take a risk with a secondary glaucoma is a question. I think it's all individual surgeon-based decisions. I don't think.
I have been using this triamcinolone very frequently before coming here.
Yeah, I know. Here you are using, I think,
even now. Actually, I think one thing which you can check is that, like as Dr. Sai mentioned, if any past history of IOP, rise and all those things with any use of steroids, then better to avoid, because the strong steroid responders comes less than 5% of the population. So maybe in case, unfortunately, if your patient fits into that category, then whichever the steroid you give, then you land up in trouble. So there were occasions where when one patient, I had to even do vitrectomy and remove all these TA particles as far as possible, and then take the patient for a TRAB also. So maybe that strong responder categories are the one which actually cause problems. Get problems when you inject these transfer. So the history might help. And when we have other alternatives, only in those poor patients or somebody who cannot afford these multiple injections with anti-VEGF, still can consider.
I have always wondered one thing. Is Ozurdex, can it be used in NVG? For the inflammatory part of it?
But I think that VEGF is more actually, because you need an immediate action in when you treat these cases of NVGs. And I don't think that steroids will immediately take care of that. So anti-VEGF, actually, you see that the very next day you will see that the it gets blanched. And steroids will not, because we want that faster action in these cases of NVGs. So I think, but very rarely in those patients who, if there is a strong contraindication of anti-VEGF, then we have this option of giving steroids, because it does have some action.
Ramya wanted to ask something, no? You raised your hand, then you
Ramya, please.
Sir, you were mentioning about the use of Ozurdex in post-vitrectomized eye as a first choice.
I have not said. It is the
study. So, do you? Would you consider, and what are the precautions to avoid hypotony?
Yes, very good.
That is something which we often, and the speed with which the Ozurdex pellet would go inside. That is something which I am actually worried about.
So in a vitrectomized eye, definitely we should have a more, the tunnel has to be very good, because otherwise you may end up in a hypotony. So hypotonic maculopathy can also occur additionally to our macular pathology. That is one thing.
No. The direction should not be towards the macula.
Correct.
That is because the vitreous is not there to tamponade or decelerate it. So the direction should be little nasal to this thing. But I have not seen anything going and hitting and creating a break or anything. Theoretically possible.
If it is a pseudophakic eye, you can probably direct towards the lens also.
Yeah.
If it is pseudophakic, you can
don't hit the PC,
slightly anterior. It won't damage the PC. Slightly anterior.
It is so safe that even I give so many Ozurdexes along with cataract surgery.
Okay. So, is there anything else, or then Mahesh or Thomas can wind up?
Anything from Allergan side?
Someone from Allergan, do they want to speak, Gopal?
No, they said no.
Okay, fine.
Thomas?
It was a good discussion to have after so many months of inactivity. And thank you all the presenters for bringing the good cases and discussing. Our special thanks to Giridhar sir for being here. It's nice to see you, sir. After so many months.
YouTube views, Gopal? $249. Not
That's
bad.
$249.
For a focused meeting, not bad at all.
And thank you, Allergan, for organizing this. Once again, thanks to everyone. Let's call it a day.
So probably the next meeting, we can have it next month.
I have suggestions. What I was just thinking after today's meeting is, number one is, I think when these cases are being presented, after the case presentation, you can have a discussant